Hello, and welcome to Hill Country MHDD's podcast. We are now called Beyond the Label. First, we're going to talk about some upcoming events and what we got going on in the organization. I would like to introduce everybody first so everybody gets the lay of the land of who we are.
All right. Hi, I'm Chris Steinke, Dr. Steinke, psychiatrist, and chief medical officer for Hill Country.
And I'm Tyler, the communication specialist.
Oh, yeah, and I'm Kelsey.
Already starting with the jitters of the first episode.
Yes. Anxiety is real.
We all deal with it.
Yeah. Some better than others.
So what we're trying to achieve with this podcast is essentially we want to be able to use this as a space to kind of share knowledge in the mental health world, share recovery stories, bring people from the community and kind of help expand upon the work we do, the impacts we have, but also explore different avenues of where we can continue to support the 19 counties we cover.
And our 19 counties are actually pretty far. We have our big administration office here in Kerrville, and we have the I-35 corridor, and we go all the way down to Del Rio. We even have Schleicher County, Mason, Junction, rural counties. Our heaviest population is Hayes and Comal County. We have a diverse range of people that we are proud to serve.
Absolutely. And as Kelsey was talking about with the upcoming events, we have two pretty big events that are coming up next month for May's Mental Health Awareness Month. We have the Fredericksburg School of Wellness and Recovery that's taking place at the Fredericksburg Market Plaza.
Yeah.
It's going to be from 12 to 3, and it's all based around Harry Potter. So those who are Harry Potter fans, please come out, represent your house, and learn some good coping skills while also connecting with the community resources. Then in Kimball County Junction's office, they're having a summer theme carnival where they're going to be featuring one of our mobile clinic vans and having carnival themed events centered around connecting with the community, allowing people to come in and learn about our services there to help them find their way to recovery.
Yeah. And then in New Braunfels, they're having an art show, which is really exciting. So if anybody has any kind of art they would like to donate, hit me up.
And I believe Lano as well.
Yeah, Lano's having one as well. But that one's going to be cool too, because that's going to be featuring kids art.
Oh, wonderful.
So yeah, kids art, and we'll be able to vote on that. We'll have a live voting system on Facebook. And then one thing I'm really excited about as well is on May 30th, we've partnered with the San Antonio Missions team, and we will be out there promoting Mental Health Night with some other local mental health authorities and some resources from Uvalde. And Todd, our CEO, who is famous for throwing the first pitch at games, will be out there throwing his first pitch. So we're pretty excited about that. And then they're also auctioning off jerseys that the players are going to be wearing in support for us for helping raise funds for our services. So yeah, May 30th, and we will have a discount link as well available to people. So Zach will email you that. Maybe. Oh yeah, he's not here. Sorry.
But as we come across more events and things that we're going to be participating at, we'll be sure to let everybody know in the podcast so that way you can be up to date with future events and learn how you can support us while supporting the community.
And another thing, we are able to make all 19 counties that we serve May's Mental Health Proclamation Month. So we'll be out in all of our counties with those proclamations. So it's pretty exciting.
Awesome.
Cool.
Enough about us.
Yeah.
Let's focus on our guest at hand, Dr. Steinke.
Yes.
Okay.
So I told you a little bit before this, I don't really know much about you, and I would like to know more about you. So let's get into how you started your profession, where you went, and then how you decided to come to MHDD.
Okay. So it's a long road to become a psychiatrist. So for undergrad, I went to Texas A&M and then on to medical school at University of Texas, Houston. And then from there, I went out to California and did my psychiatry residency at UC Irvine down in Orange County. So I was there for 4 years. Took my first job out of residency in San Antonio at CHCS, actually.
Oh, really?
And yes, I was there for a few years working outpatient and met a colleague there, Dr. Victoria Trickett, who is now the assistant medical director at the state hospital in San Antonio. But she clued me into a new opening out here in the Hill Country for an inpatient facility called CSU, the Crisis Stabilization Unit. And that was back in 2009. And so the two of us looked into it, and we both left CHCS and came and joined Hill Country in 2009 at the CSU. So basically right when it opened. And we were there together for a number of years. I came in as the medical director for the facility, did that for 5 years. And then our medical director for the organization, Dr. Rob Ward, he retired, moved on. And so then I took over his position back in 2014, 15, that transition. And so I've been in that position really since that time.
Fun fact, my mom worked for you when the CSU first opened back in 2009 too.
Oh, wow.
I think she was she was a nurse out there, and she has high things to say about you.
Oh,
so
nice.
it was cool.
Good to hear.
Yeah. But yeah. So can you tell us a little bit more about the CSU and what the purpose is for that?
Sure. So the CSU, again, it stands for Crisis Stabilization Unit, and it functions similarly to a psychiatric hospital, but we're really just a step below. We're supposed to be a diversion to help people not have to go to the hospital. They come to us instead, and we're a short-term treatment facility. It's supposed to be treatment done within 14 days. And we take people that are in mental health crises, right? So typical example would be someone presenting maybe to the emergency room, and they've been having worsening depression, maybe having suicidal thoughts, something like that. And they would be admitted to our facility where we can treat them and hopefully get them stabilized within that 2-week period.
So what's been the hardest challenges or the barriers for people to access that type of care?
As you stated, we're spread out, right? So we've got 19 counties that we cover, 22,000 square miles. So that's one of the barriers, right? If you have a crisis that occurs out in Del Rio, which is pretty far from us, just getting them from there to here is a challenge. It typically involves law enforcement. And so assessments at the hospital, so they could come via EMS. So just navigating all that, just the distance itself is a big challenge. That's one of the biggest things I would say. And then another issue is, do they qualify? Are they appropriate to be at the CSU versus a psychiatric hospital? So we have some limitations that a psychiatric hospital might not have. We don't have security at our facility. We have shared rooms at our facility as well, which can limit the acuity of someone. So if someone needs a private room, that could be an issue. So things like that.
Gotcha.
Yeah.
So I know on top of the CSU, I know you also work with a lot of prescribers and everything. What's the process behind like how you get the prescribers for Hill Country MHDD and how you work with them?
So that's developed over the years. So we've had a number of, I'd say in the past, we probably had more contract workers where we would have a third party that we work with, and then they could recruit for us, right? So they could recruit nurse practitioners, psychiatrists, and we would have them join us that way. And we still do that some. Fast Psych is the organization we still contract with. We've used them for a number of years, but we've reduced those numbers over the years and have been able to hire more of our own staff. And one thing that's helped us a lot is our relationship with the University of Texas program, the psychiatry program out of San Antonio. And so we have so the residents are there in their training for 4 years. And during their third year, they do a rotation with us. So they're situated there in San Antonio, but then they do remote connections to several of our clinics. And so they get experience working with us. And so we've been able to recruit a few of them through that. They've decided that they liked it. And so when they graduated, they went ahead and came on and joined us. So that's been cool.
Yeah. I'm actually really interested in recruitment and retention in rural healthcare settings. That's what my dissertation is on. And I'm specifically studying leadership styles, but one thing I've found in my research has definitely been urban cities have been able to recruit and retain physicians more often because they're able to pay them the higher money. There isn't a barrier for them to have training, ongoing training, to have access to higher, better tools. Is that something that you experience firsthand?
Yes. Yeah, I think that's definitely an obstacle for us. With our outlying counties, it's hard to get someone to want to move to a location like Del Rio or Junction. So you're just not going to have that many doctors out there. They want to be in the city where they have access to what you were talking about. And not only for their training, but they have access to just the things outside of work.
Yeah.
The restaurants, the
things that don't close at 8.
Exactly.
7. Yeah.
Exactly. And so But the telemedicine, telehealth has allowed us to still work with them, because now what we can do, they can live in San Antonio or Austin, and then they can work from home and connect to our clinics in these outlying counties. And so it's been a huge, without that, it'd be a big struggle.
Yeah, for sure. I forgot what question I was going to ask.
I know one of the things that we wanted to touch on, because me and Kelsey were talking about before starting the podcast, was the ambulatory and outpatient services. And both of us have a general knowledge of what that work is, but we both would appreciate a breakdown of that. But I'm sure also our listeners would love to be able to hear that, to understand what goes on in the background of this work.
Sure. So we see children as young as probably, I'd say 4 or 5 years old, and then all the way up to geriatric. And for the kids and the teenagers, we have child psychiatrists that see them. And so they're seen for a number of issues. And so whether it's somebody with autism and ADHD, those are very common things that they'll see, but they see it all during those ages. As you get to the adult age, historically, the state was really focused on what we call the big 3 diagnoses, which was major depressive disorder, bipolar disorder, and schizophrenia. And so that's what the focus was. Yeah. But now we've really expanded to include everything. So we see, you name the diagnosis, and we treat it and we see it. I'd say if someone has one of those big 3 diagnoses, that does tend to be the primary focus. But again, if they have PTSD, generalized anxiety disorder, maybe some substance use disorders, we'll address those as well.
Can you go a little bit more about the big 3 and what signs and symptoms are? I know schizophrenia usually develops later or showcases later in life. And so if you could just run through those and just let us know a little bit more.
Sure. Major depressive disorder would be the most common out of those 3. And what people are probably more familiar with, depression, it's more straightforward, I would say. It's something that you've heard before. Yeah. So it's textbook wise to have the MDD diagnosis. Symptoms have to be there for at least 2 weeks straight or longer. And someone, of course, they're going to be sad. They're going to be feeling hopeless, helpless, lose energy, interest, drive. They might not be sleeping, they lose their appetite. So all those symptoms, of course, they can feel suicidal, right? And sometimes if it really progresses, they can become psychotic as well, where they are hearing or seeing things that you and I aren't, right? Or believing things that no one else is, just they're believing it, and paranoid. So it can progress to that. And usually if that happens, that's when they're going to need to come to our CSU or an inpatient facility for treatment versus outpatient. Bipolar disorder and schizophrenia, there's some overlap there with those. I'd say the big difference with bipolar disorder, it's more, people will hear mood swings, right? That's a common thing that people say, but it's more complicated than that. There are 2 different poles, basically. So bi means 2, right? And so there's 2 poles. There's a manic pole and there's a depressed pole. And to be bipolar 1, which is the most severe, serious kind, you have to have had a manic episode in your life. And so that manic episode is at least 7 days or longer when they're in this mood state and they look like a different person. And so I'll explain this to people. Other people would notice it, but the person that's in that manic episode, they tend to not understand. They don't see it. Everyone else can see it, but they can't see it. And when they're manic, their mood is what we call elevated, high energy. They're not sleeping because sleeping is the last thing on their mind. They have other things flying through their minds. And so sometimes to the point where they're delusional. They think they've written a masterpiece and they want to show that to everyone, and you've got to read it, right? But again, they don't understand. They don't have the insight into what's going on. And they also can become psychotic that persists, and delusions, paranoia, hallucinations, all those things can happen. And typically what will happen is if it gets to that point, they'll end up in the hospital, could end up with an encounter with law enforcement, maybe an arrest, maybe an accident, end up in the hospital. So that's usually how we get their attention, and then getting them on some medication to stabilize their mood is what's needed. But once they're stabilized and doing well, someone with bipolar disorder, you might have no idea that they have had that happen to them before. They can look like anybody else, functioning well, have a job and family and everything. As opposed to schizophrenia. Schizophrenia, the symptoms, and it's not for everybody, but for, I'd say, majority, once the symptoms start with schizophrenia, they tend to stay there. And it's a downward progression over time. And so symptoms are more constant and more, you can see it. In other words, so if you treat them, you sometimes can get things under better control, but some of the symptoms, the residual symptoms persist. And so it's more evident. And in schizophrenia, the psychosis is what we call the positive symptoms of schizophrenia, which is the hallucinations, the delusions, the paranoia. And then the negative symptoms of schizophrenia, that is the effects that can happen with their cognition, ability to think clearly, ability to kind of voice a regular conversation with someone's inability to have normal social interactions. And so, and you can see that sometimes they're also what we would call up their affect is affected. In other words, their face is blunted or flat, meaning they lack expression. Okay. And so these are common things that you'll see as well. So those are some of the differences in those three.
It's interesting.
Yeah.
So what do you see the most in children right now?
So I'm not a child psychiatrist, but just looking at what our child docs see, ADHD is probably the number one thing that they treat, but they also treat the major depression, bipolar disorder. Schizophrenia is more of rare, right? Because that does tend to come on a little later. Schizophrenia and bipolar disorder, I'd say that 18 to 25, 24-year-old is when you got to really keep an eye on things. So, but yeah, so for the kids, ADHD, DMDD, so some oppositional defiant disorder, ODD, those kind of things they deal with, and the autism.
I do have a question about oppositional defiant disorder. Does that later turn into something else at a certain age? Is it called borderline personality? Is that?
No, I wouldn't say that from OD. One thing that can be concerning is if someone has a conduct disorder when they're younger. Conduct disorder is someone that's basically breaking the law, doing things that are of major concern, setting fires, maybe torturing animals, these kind of things that are very alarming. And that you have to watch because that can progress to an antisocial personality disorder. We don't diagnose personality disorders until someone's 18.
Okay.
And so, but we do keep an eye on that. Borderline personality is something we see a lot in our adult patients. It's very prominent. And unfortunately, the setup for that is trauma. Someone's been through a lot of trauma in their life over the years that can lead to the borderline personality. And it's just the way to describe that is an instability of mood, but instead of like bipolar disorder, where it's more episodic, with borderline personality, it's a day-to-day issue. So they have issues with this mood lability day in, day out, can happen multiple times during the day. And so a lot of difficulty maintaining relationships, very reactive, angry, suicidal, self-harm, those kind of things with borderline personality. And so we see that a lot. Therapy is very important to treat that.
Awesome. I love hearing all that information. It's really interesting to see a bit more on the back end of how these decisions and processes work together to support somebody in recovery. Because before my position, I was a mental health peer support specialist. So I know what it's like being that person going through recovery while also being somebody to help somebody in recovery. So always open to a wealth of knowledge.
Yeah.
But one of the questions we like to ask here, because it's always really inspiring to hear from people and hear what motivates them to do this work. It's what's your why? What is your reason for doing this work?
Let's see. As I was going through medical school, you get exposed to everything, right? And so part of it, when I started, I wasn't sure what I was going to do. And so in your third year, you have rotations in different fields, right? Different specialties that you do. And so for me, it was a process of elimination in some ways, right? So I do a surgery rotation and say, yeah, that's not for me. OBGYN, no thanks. Someone else could do that. Yeah. And fortunately, you get that exposure, get some experience, and you find what fits best. And for me, after doing my psychiatry rotation, I did an inpatient rotation in Houston. I did some outpatient. So getting to see both aspects of that, working with the different professors, you get a connection, and felt like something I could see myself doing on a day in, day out basis. That's the other big thing. I think you've got to visualize that, right? Yeah. So, because it's a long career once you commit.
Yeah.
So that's kind of it. I have a cousin with bipolar disorder, bipolar 1 disorder, that kind of materialized as I was going through my training. Actually, it wasn't really the reason I went into this, but it happened. So for me to be during having my training going on while that was going on was interesting, and it reinforced what I was doing. Right.
Absolutely. Love that.
Yeah. I guess for people who are struggling with any of the big three, any kind of other mental illness, me, I've got ADHD, anxiety, depression, like I'm medicated, go to therapy. What kind of hope or what kind of advice would you give family members or somebody who is walking through this day in, day out?
Yeah, I think connecting, right? Finding someone that's going to be able to help you, right? Not being afraid to reach out for help. We have locations throughout our 19 counties, lots of different clinics. We're launching our new mobile clinics that are going to be going out to the rural areas to help people that have trouble with transportation. So increasing access for people. But yeah, just to know that there are people out there that can help. And even if you don't have insurance, or even if you don't have a job, right? So that's why we're here. So we have means to help people that are struggling and they're in that situation. And like you said, if we can find it, if it's a medication that's needed, staying on that medication, being consistent, communicating, being honest with your doctor or your nurse practitioner that you're seeing, very important. And then therapy too is key piece. We have our care coordinators that offer some supportive therapy and guidance with social services. And then we do a lot of cognitive behavioral therapy in the clinics. Yeah. And so the CBT is great for depression and anxiety, which are, I'd say, two of our main things that we see. Number one these days, as far as diagnosis, would be major depression and PTSD. And I think those are our two most significant in the adult population.
Absolutely.
Yeah.
I don't want to take up any more of your time. We appreciate you being here.
Sure.
Yeah.
Thanks for having me. First podcast for me.
Was it really? You crushed it. You crushed it.
All right.
Crushed it.
Yeah. You did amazing. So we're going to kind of wrap it up here. And we want to remind our viewers that there's always hope and there's always somebody that you can reach out to. And we're one block away, one phone call away, what it is that you need for support. So we encourage anybody and everybody that's listening to please reach out. Even if it's not to us, reach out to a friend, a family member, the dollar store clerk you may be going into, and you run and have that conversation with whoever that person is for you. Like maybe this is your call. Reach out today and check in on them, or even just do a check-in on yourself.
You're not a burden.
No, absolutely not. And if anybody makes you feel that way, we'll always be here to stand by you and say, no, you're not.
And kick some booty. All right. Thank y'all for listening, and we'll be back again in 2 weeks.
Yep. Sounds like a plan.